Mantle cell lymphoma is a unique disease. It's a very difficult disease, and we have a lot of different treatments depending upon the actual patient characteristics, the cancer characteristics, or the biology of the mantle cell lymphoma. But for younger patients and patients who are fit and who don't have comorbid illnesses, when we diagnose them, if they have the so-called aggressive variant of mantle cell, they get fairly intensive therapy. They get a combination chemotherapy, chop-rituximab, usually also with a platinum type of drug interspersed in between, and then they go to a high-dose therapy and stem cell transplant, and then they get maintenance Rituxan. Now, that treatment has evolved over the years, and that's a treatment which has been shown to have some survival advantages over standard, less aggressive treatment approaches. And in addition, there may be a little bit of a plateau. There may be some patients who get that treatment approach and actually are cured. Well, I mean, at least they go for a long time without evidence of recurrence. So now there are many patients who are, let's say, older, who have comorbid illnesses, who are not candidates for that type of intensive treatment. And for those patients, we have a more gentle type of approach. It's an approach that we use for indolent type of lymphomas. It's probably a bendamustine type Rituxan combination and maintenance Rituxan. So there are different treatments depending upon those different features that I mentioned for first-line mantle cell lymphoma. So relapsed and refractory is even more difficult because we don't really have a standard of care treatment for relapsed mantle cell lymphoma. And as you can see, the patients who relapse are going to come from different pots of therapy, some who've received very intensive therapy, some who've received gentler therapy. Now it very much depends again on the patient characteristics, how well they are, how long it's been since they've relapsed, what initial therapy they received. If there are patients who had, let's say, bendamustine and Rituxan and had Rituxan maintenance and went for quite a while before they relapsed, they might get a very similar sort of treatment. But generally, we use palliative type approaches in these patients, gentle approaches, mild chemotherapy, maybe low doses of metronomic type of chemotherapy. We very rarely use aggressive approaches when patients relapse. Occasionally there may be a very young patient who relapses, who may not have had, who may be a candidate again for a transplantation approach. Most recently we've had some new drugs that have become available for these patients, and they're starting to change the landscape on how we manage these patients. And these are, of course, the BTK inhibitors, the first one being ibrutinib. And there's been some really nice studies of ibrutinib in patients with relapsed and refractory mantle cell lymphoma, and actually it's a very good drug. It's a drug that's given orally. It's a specific targeted agent. It's not a cytotoxic drug that indiscriminately kills normal and tumor cells. It's really focused on the mantle cell lymphoma cell, and it is well tolerated. Patients take it orally. They take it continuously. Often they take it. They don't stop taking it as long as they're responding, and it is able to control their lymphoma, not cure their lymphoma, but put it perhaps in remission, or at least partial remission, in probably about 60 or 70% of patients, with a fairly favorable toxicity profile. So we're starting to use more and more of that approach for patients with recurrent mantle cell lymphoma. It's an approach that's approved in for example, the United States. It's a little bit more difficult to get in Canada.